and then we will see what South Africa brings us. Have we got anyone on from there yet? Not yet.
We're going to start.
Okay.
Honorable guest, we will go live in next 30 seconds. We'll give you the cue.
Anubhav, any luck with Asha George?
We have mailed her, sir, but waiting for her response.
We
Okay.
can just, we need to mention she was invited, so it doesn't look like only a male-dominated panel. Sorry to say that we do have a woman, and she cannot join for internet connectivity issues because she does work in health systems.
And
I leave it to Tim.
We are live. Whenever you are ready, Dr. Evans.
Okay, so it's welcome to this last session of the conference on COVID-19 and the future health systems. And this is the last session, last of the 6 sessions, scientific sessions that we have. We had very lively sessions in the past, 5 sessions. So we look forward to this penultimate session on the future health system and what you have learned from COVID-19 for the future health systems and how we can make best use of the crisis that we are in. For this session, we have panelists, but the session will be facilitated and led by Dr. Tim Evans. Tim Evans is the Director and Associate Dean of the School of Population and Global Health at McGill University in Montreal, Canada. So with these few words of introduction, I hand over to Tim Evans to take it forward. Over to Tim.
Great. Thank you very much, Dr. Chowdhury, or as I would prefer to refer to you, Mushtaq Bhai. It's wonderful to be here, and many thanks to you and the organizers of Bangladesh Health Watch to allow us this opportunity of closing session today at your meeting. We are looking forward in this last session, and to do that, the organizers have assembled a tremendous panel, which I'll just introduce very quickly, and then we'll ask each of them to provide some initial remarks to get the conversation going. And for all of those who are listening, we encourage you to listen actively and to feed the chat with your questions such that we can have a lively discussion on some of these issues, which will offer some thoughts. So we'll have 5 panelists who are going to get the conversation started. We have Dr. Kwok Kian Woon, who is a professor and associate vice president of the School of Social Sciences, Sociology faculty, and associate provost at the Nanyang Technological University in Singapore. We have Dr. Sushil Chandra Baral, who's the managing director of HERD International in Nepal. We have Mr. Rob Yates, who's the executive director for the Center for Universal Health at Chatham House in the United Kingdom. We have a Dr. Anindya Chatterjee, who's the regional director, Asia Regional Office of the International Development Research Center in India. And we have Dr. Asha George, who's an adjunct professor of health systems at Johns Hopkins Bloomberg School of Public Health, joining us from South Africa. So welcome all to our panelists, and thank you in advance for joining us today. As I said, each of our panelists now are going to provide us with some introductory comments and remarks related to the focus of this session, which is really thinking about how we prepare for the next pandemic, what kind of post-pandemic health system we'd like to see, and what needs to be done to ensure an effective, equitable, and accountable system. So those are the very simple questions we've been given to answer, and we look forward to the audience, those listening, helping us in following these presentations. So we're going to begin with Dr. Kwok Kian Woon. Over to you, Dr. Kwok.
Thank you so much, Dr. Evans, and hello everybody from Singapore. It's my pleasure to be here. Thank you for inviting me. Let me just open up by noting the forward-looking thrust of this conference, but at the same time note that this prolonged, protracted crisis is still going on, and there are questions about how it will still evolve, including the question of the possible next variant. And even with Delta, the experience of Delta, the lessons of that earlier period might not even have been followed through with the Omicron. So if we are looking into the longer term, and in the early phase of the pandemic, it's been said that this is a once in century phenomenon, this pandemic, this global pandemic. Now, the Spanish flu of about 100 years ago was indeed quickly forgotten. And one wonders about the memory of COVID-19 in the years and the decades to come. So I think I would like to pose this question of how in the longer term the pandemic will be remembered and its lessons will be taken to heart. Because in the heat of the pandemic, we have seen disruption, we have seen devastation, a great deal of desperation and despair, as well as deaths, and the numbers across the world has been stunning. And while we have been looking at lower income countries, even higher income countries and first world countries have been found to be wanting, have been found to be failing in the process. So this is more than just a wake-up call. It's something that is of such great significance. And how are we going to live up to these painful experiences, which we say must never be repeated again? So I think this kind of questioning has to have a long life. Now, it's been said that certain countries which had experienced SARS, for example, did better in the early phases of the pandemic. But indeed, all countries, including those who experienced SARS, did experience many challenges, and there were all kinds of mistakes that were made and so on. So I also feel in particular for, say, those of us who are teaching in universities, our students who, for example, the freshmen of the last couple of years who have been experiencing their university life, much of it online and without a great deal of the kind of social interaction that pre-COVID our undergraduates or even our graduate students would have had. And this generation in their 20s and their 30s, it's well possible, very possible within their lifetimes that there will be another pandemic even in the years ahead, not to talk about the decades ahead. So there are many things that we have to think about in terms of education, and of course, as many of us have noted, also in terms of public education. Let me now come to some reflections that we've had in some previous projects related to COVID-19. There is the question of viewing this, as the conference materials have said, as more than a health crisis. It is, in fact, one crisis amid other crises, and it is, as Richard Horton has said in the Lancet, not just a pandemic, or in fact, he said, not a pandemic, but rather a syndemic, in which the it's not just merely about comorbidity, I quote, but syndemics are characterized by biological and social interactions between conditions and states, interactions that increase a person's susceptibility to harm or worsen their health outcomes. So I think this broader view of health, and by extension, a broader view of medicine, a broader view of science, and in particular, it has to incorporate a more integrated, holistic, and systematic consideration of many factors coming together. And this integration, this way of looking at things needs to be worked out in the years to come, and not only applied in a mechanical manner, in the manner of box ticking, but really in a manner of addressing fundamental changes that will prepare us better for the next pandemic and also for other interrelated crises. Now, in this connection, I would just like to say that state capacity is important, but in Singapore, we have very strong state capacity and a whole of government approach, but the state and the government cannot work alone without reaching out to the public, and certainly without the help of civil society and civil society actors. And there is another actor, which is academia. Now, academia is not always well positioned to respond very quickly to a pandemic, because its norms are about research taking time, peer review and publishing, which may take many months, if not years, and so on. So again, academia has to re-examine itself, working with the state and with civil society in the process of responding in a timely way to the pandemic. I think one lesson learned, of course, has been public communications and public education, and I feel no doubt that this topic will come back again. So can I just end this set of reflections by turning to a phrase which has come up very often during the pandemic, which we all hope would not become a cliche, but something to be taken seriously. And that phrase is, no one is safe until everyone is safe. And this applies not only within societies, but across societies, and of course across the globe, especially with questions about vaccine equity and so on. So I think the possibility of such a phrase becoming a cliche is very real, because of all kinds of reasons, including material and other kinds of interests on the part of individuals, groups, and whole countries. I think I'll end there for the moment. Thank you, Dr. Evans.
Wonderful. Thank you so much, Dr. Kwok, for those really great introductory remarks. You've given us a wonderful alliteration of Ds, disruption, despair, devastation, and deaths, which have characterized the last 2 years, and have put a big emphasis on learning, not only formally, but in the public, and integrated learning with respect to the idea of syndemics, multi-sectoral approaches, and the risk that there may be a cliche that no one is safe until everyone is safe, and to avoid that becoming a cliche. Thank you. Excellent start. And now we'll move on to Dr. Sushil Chandra Baral.
Thank you, Chair. Distinguished panelists, participants, colleagues. Thank you for this opportunity. My name is Sushil Baral. I work for Herd International. I also work as a consortium partner with the Corals Research Consortium and Reveal for Resilience. Both are pretty much focusing on health systems. Good evening, and from a very cold Kathmandu, it's getting freezing these days. I bring the perspective from Himalayas, where the pandemic has hit us badly in many ways. But I'll be talking more about the primary health care, what to rethink in primary healthcare in our context in post-pandemic situation. We all know that health has been recognized as a fundamental human right. There is no doubt, yes. However, the means to get the fundamental rights secured for the population is the universal health coverage, which has been quite a lot talked across. Before the pandemic, during the pandemic, and we'll be talking for many years about UBC as a critical means to achieve the health as a fundamental right for the population. It has aspirations. I wouldn't go detailed. We all know these aspirations that the care, high quality of care is provided when there is needed without any financial hardship. Also, it has a lot of contribution USC brings to the society and the well-being from the gender, equity, social, and economic contribution. How all these things is possible? How can we get this thing done in the course of our time? Is the strong primary healthcare, which is the foundation for the quality health systems that ultimately leads us to universal health coverage. Why this is important? We all know that why the primary health care is important. It is the first point of contact, not only for an individual, for the family and the community as a whole, and which is closest to people. We all understand that. But how far this has been in practice during the pandemic, we need to unfold that reality. Also, it's an integral part of the health system. PHC does not stand alone. It's a part and parcel of the health systems in a country. How far this PHC were used or thrived during the pandemic, this is the biggest question we need to unfold. Also, high quality of care that can be affordable to the people, and it's scientifically proven. That's why the primary health care to us is the powers the health system, making the health system more resilient, that saves the life. I just want to present this pathway to rebuild, which I borrowed from the Rebuild for Resilience research framework. I mean, these are various dots here we see. Unless these dots are connected to each other, we will not be able to have a strong primary healthcare system in place. The health system's capacity, the primary healthcare's capacity in terms of stand and continue to deliver its services. Its absorptive capacity, its adaptive capacity, and transformative capacity. These three capacities by having these various dots connected, be that social networks and collaboration or the information and dissemination, which are critical to the to deliver the primary healthcare system to a result, and the availability and capacity of the motivated human resources. But what are the shifts we should be looking for in the next course as we continue to deal with the pandemic and post-pandemic situation to make our primary healthcare more strong and delivery? I think it's important that we have been talking primary healthcare for a long time. However, this pandemic has clearly demonstrated that the quality of health services are of low, and we have not been able to achieve the coverage. But now we should move to high quality for all. How do we do that? That's the big question. We have been seeing during this pandemic and before that's a level of fragmentation in the service, but there was a lack of coordinated care during the pandemic because our primary healthcare system was not that strong enough to coordinate the care across the board. And it was not patient-centered. Lastly, the provider-centric biomedical focus of care has been there for a good number of years. The coordinated and person-centered care is the essential for the next. There's a gross inequity in health outcomes, because we do not really, we were not designing our health systems and the primary healthcare in particular towards more inclusivity, the fairness, and making it more accountable. So this has clearly revealed during the pandemic process. The partial existence or non-existent of the care towards the comprehensiveness and the continuity of the care is the next what we need to look for. Also the fragility. I mean, there are lots of fragility. During this pandemic, our primary healthcare system was stressed, was overwhelming in terms of providing care that is needed for the population. How we can make our health system to be more resilient in the long run, so it continue to absorb the shocks, and it becomes more. It has a resilience capacity to transform the shock towards a thriving primary healthcare system. That perhaps is. How do we do that? I mean, three big, important elements I would put forward here is the multidisciplinary, coordinated, a collaborative health workforce for primary care, which is evident, and we seriously felt the gap of having a multidisciplinary team working at the primary healthcare centers across the country. Also the community. We all talk about the community engagement. However, I put here more than the engagement, empowering community towards co-creating solutions to their local health needs. That's really vital. We need to redefine the process that we engage community traditionally in primary healthcare system. We need to have new ways of delivering it. And the third is sustaining the financing, which is the backbone which we need to take. So this is my last slide. A few thoughts that perhaps important, I think, here is me being started as a career as a primary healthcare worker in Himalayas. Strengthening PHC is a hard grind. Really, its task involves multiple actors in place. So what I have realized over the years, and particularly during the pandemic, is the leadership matters at all levels, not only at the federal level, but also the provincial, district, and the local level is important. Successful reforms that we have talked quite a lot, that need to be laid, then only desired. That's why the continuous reflections, lessons that need to be geared up. Despite during the pandemic, PHC had lots of adaptation based on the different waves and context that we lived in. However, the changes are unlikely to be lasted. The changes that we instigated during the pandemic are unlikely to be lasted if the basics are not addressed, are not met, or partially met. So comprehensiveness and continuity remains a priority in order to strengthen the primary healthcare. Last but not the least, health workforce and community are the fundamental. So higher investment towards its effectiveness is a must, which is a non-negotiable. Over to you. Thank you, Chair.
Great. Well, thank you very much, Dr. Baral. And you've engaged PHC, primary healthcare, as the vehicle for universal healthcare systems and or health systems, and have given us some of the complexity that's involved in moving in that direction with respect to better absorption, adaptation, and transformation, and looking at how some of the challenges related to the performance of systems can be addressed through three critical resources: the workforce, community resources, and financing, provided you've got adequate leadership, that you're learning lessons, and that you keep on sustainably investing. So wonderful compliment to our first presenter, and we will now move on to our third presenter, Mr. Rob Yates.
Thanks very much indeed, Tim. Greetings from Chatham House in London. I'd like to take, if I may, a political perspective and also an optimistic perspective that potentially the COVID pandemic is going to throw open a political window of opportunity to catalyze a new generation of universal health coverage reforms. Why do I say that? Well, clearly, as previous speakers have said, we've just had this massive, we're still going through this massive health crisis, the worst in over a century. and it's requiring immediate action at a head of state level. All of a sudden, health is top of the agenda of heads of state across the world and requires interventions across all government areas. Particularly where it's being felt most acutely, not surprisingly, people want access to health services, vaccines for everyone, treatments if people fall sick. There's a clamor across the world for people to get access to health services. And these are universal entitlements. This virus affects everyone. Everyone wants to feel that they can get health services and want to get them quickly. And people want to see dramatic action from their governments, and they want to see results quickly. Now, if you combine those together, one can see that it really calls for approaches like universal health coverage. Everyone gets the health services they need with financial protection. So we're seeing right across the world, if I could just move my slides on, that pressure is being put on political leaders. Some leaders are stepping up and are taking action, and others are failing. And as a consequence, they are feeling the political heat. We've already seen the demise of President Trump, largely due to his COVID response. We may be seeing a similar thing here in the UK with our Prime Minister under great peril at the moment, largely to his personal response to the COVID crisis. President Bolsonaro in Brazil as well is also feeling the heat due to his response. So all over the world, politicians are recognizing that they need to do right by their populations in their COVID response. Now, we have seen throughout the centuries, or certainly the decades, that crises are a great way to catalyze universal health reforms. My own country here in the UK, when we were a post-conflict state at the end of the Second World War, when we were dependent on US aid, we launched the National Health Service when basically the country was bankrupt. One of our greatest achievements, and I'm sure Tim would say similar things about the achievements of Tommy Douglas in Canada. And we celebrate it to this day, that like when we held the Olympics in 2012, and that was the Olympic Stadium spelling out the National Health Service. Japan as well at the end of the Second World War, when its financial situation was even more precarious, launched its universal health reforms, and to this day is a great champion, political champion of UHC, as shown by the former Prime Minister launching this conference in 2017. But more recently, we've seen other crises create UHC reforms. The Asian financial crisis of 2000-2001 that brought to power Prime Minister Thaksin in Thailand. And one of his great reforms was to introduce a universal health system entitling everyone to a publicly financed health system. And to this day, he's venerated as a hero by the poor in Thailand for what he achieved with his UHC reforms. And very significantly, when one looks at the Chinese health reforms of the mid-2000s, which followed a period when it was drifting into a privately financed system, it was the SARS epidemic that really made the Chinese government realize that their health system was failing and they needed to re-socialize the health financing system, take the burden away from households and publicly finance the system. And as we've seen that, China has responded very well to this pandemic with its publicly financed health system. So that's been the history, but we're seeing it played out through this crisis now. So looking at countries that have said they're going to use this crisis to catalyze UHC reforms. President Ramaphosa in South Africa is saying that he's going to use this to catalyze national health insurance reforms coming out of the crisis. Egypt, where they've said they're going to accelerate their program. They were attempting to have UHC by 2032, but now the aim is to do it by 2027. And a fascinating country, of course, the United States, where in the run-up to the last presidential election, Hillary Clinton using this expression, "Don't let a good crisis go to waste," and very much encouraging President Biden to introduce a publicly financed health system in the US. Whether he's going to do it or not, we're not sure yet, but we're seeing some states like California and New York seriously thinking about introducing a publicly financed system. And I keep emphasizing the importance of public financing. The key to UHC is switching from a private voluntary finance system to a publicly financed system, as articulated by Gro Harlem Brundtland at the special session of the UN in 2019, just before the pandemic. And just to illustrate this in a graph, here we see countries that at the beginning of the century were quite low spenders when it came to public spending, but various crises, so there are the taxing reforms, these are the Chinese financing reforms, and Iran has seen huge increase in public financing, moving them more towards a socialized health financing system. But you see a good number of countries down here still languishing at about this 1% GDP public health spend. The big question is which of these are going to use this crisis to replicate what these countries are doing? And very much thinking about our current audience, might this be the time that Bangladesh takes that big leap towards universal health coverage? It will require about 1%, maybe 2% of GDP plowed into the system. And I think this will be a tremendous opportunity for Her Excellency Sheikh Hasina to do this, and very much encourage her to grab the opportunity and to become Bangladesh's UHC hero coming out of this crisis. So thanks very much indeed, Tim.
Many thanks, Rob. You've taken us right to heads of state and heads of the UN, former Director General of WHO, Gro Harlem Brundtland, and have basically given us the opportunity in the crisis approach and noted that there's not only historical precedent, there's evidence across a number of countries at the moment of using this moment of crisis to really push forward reforms that are not only long overdue, but may serve us well in the future. And so I did note, and I would love our Bangladeshi colleagues to respond to the gauntlet that Rob has thrown down with respect to what the future looks like in Bangladesh with respect to universal health coverage. So with that, we're going to move now to Dr. Inindya Chatterjee. Over to you, sir.
Thank you, Chair. Great pleasure to be with this very distinguished panel. Also, special thanks to Dr. Chaudhary and Sabina for this invitation to speak. Now, I'm going to speak about knowledge systems in low, medium income countries and related issues of leadership and governance of evidence production and news during this COVID pandemic. And I'll start by making a few fearless statements. By making these statements, however, I do not want to obfuscate the differences in country contexts on knowledge production and use. If I get a chance, you will see that is where I will come back to. Firstly, one of the key aspects of the pandemic, as we all know, is inequality. Inequality of data and evidence production and use, availability and uptake of vaccines, availability of intensive care beds when needed, resulting in differences in outcomes in affected individuals and communities. We have seen that. Let's start with data. There's tremendous upsurge in data gathering and publication of scientific articles on the one hand, somewhat unprecedented in history. On a quick scan of data analytic domains and publications, we can easily identify areas such as epidemiological research, modeling, projections, surveillance testing, contact tracing, including with mobile phone apps, and genome identification and surveillance, public health and social measures, healthcare system preparation and readiness, clinical data, data on response, economic and social impact, and so forth, produced by both public and private actors. However, this explosion of data and publications is highly skewed. We are yet again in a situation where global recommendations are based on skewed data, rich data from some country contexts, and elementary from others. If we look at the situation of evidence production by public institutions and ministry departments in lower middle income countries, the picture is mixed, of course, and there are some very notable exceptions, but we can come to this conclusion that these institutions have often not delivered beyond basic data, such as how many tested against how many positive and vaccine doses delivered, etc. The lack of systematic data stands out, for example, in the areas on social impacts, intimate partner violence, learning outcomes of school children, economic impact on vulnerable populations, such as informal workers in South Asia, mental health, impact on continuum of care for antenatal populations, chronic health conditions, treatment of cancer, impact on frontline health workers, and so forth. We do know from local experience and also from global publications and experience that these are very important aspects of the pandemic. But studies on nature and extent of these for national and sub-national levels has not been easy to come by. Secondly, collaboration between public institutions, government departments with independent research institutions or think tanks, universities on data and evidence has not been uniform. This also points to collaboration with civil society actors who are very important players in many settings, delivering services among the most vulnerable and are working towards the goals of national health programs. And thirdly, the nature of political discourse has changed in the last decade, including in many parts of Asia, with a high-pitched contestation on every issue becoming the norm, as if we are living in the middle of a never-ending election campaign. Rapid information dissemination aided by technology has resulted in the existing gap of high-quality data from many settings, frequently filled by hearsays, contradictory statements, and malicious misinformation. There has also been political fallouts and consequences. We have heard that from panelists, my previous panelists. So this has somewhat altered the use of evidence in many contexts. Evidence is not the only driver of public health or societal response. It never was. But now it is even more complex and in a state of flux. So we are facing with a number of challenges on the data front, particularly from LMICs. And I want to highlight four going forward issues, aspects that I would like to see in future health systems. And these are looking back at past experience of handling SARS, emerging infectious diseases, avian influenza, HIV/AIDS. Somehow, many of the lessons learned through these, living through these epidemics has taken the back seat, and we need to bring it forward, particularly global access to antiretroviral medication for HIV and similar experiences. Secondly, we need to look at the issue of use of evidence through collaboration with decision makers. 3, researcher community collaboration. And the 4th, human resources for health, frontline health workers. These are the 4 issues I'm parking for the moment. And if I get a chance, I would like to come back to at least some of them so that so that we can have a good discussion and I can make some further comments. So thank you very much. Over to you, Tim.
Great. Thanks, Dr. Chatterjee. You've given us the focus on inequality being something that is permeating through the pandemic experience. You focused in on the surge in data and identified a number of issues that are concerning with respect to the skews in production, which relate to institutional capacity, areas of importance that are neglected, challenges in collaboration, and this increasing polarization and misinformation that we're all facing. And then you've provided us with 4 critical areas that we'll be able to come back to in looking at learning from the past and moving right through to understanding the workforce as opportunities for moving better. So we look forward to coming back to those issues. But before we do, we're going to go to our final panelist, Dr. Asha George, and we're delighted, Asha, that you've been able to join us, knowing that you've overcome major logistic challenges today. So welcome, Asha.
Thank you very much. I hope you can hear me clearly. Yes?
Yes.
Great. I'm so excited to be part of this panel. I've loved listening to the comments, and I made it just in time to log on. I just reflecting, I have a few key points about gender, but I just can't resist to reflect how the panelists have brought up issues very closely linked to gender. So Dr. Kwok, he talked about social disruption, and certainly when you look at gender power relations, gender inequalities, COVID-19, without a doubt, has erased decades of progress in terms of gender inequality. So I'm really glad he brought up the issue of social disruption. Our colleague, Sushil Baral from Nepal, talking about primary healthcare. It can't be delivered without women. Women make the majority of the health workforce, and they've often been they're at the front lines, but as you'll see from my presentation, not always well served by the way in which health systems have responded to COVID-19. And early on in the pandemic, I remember one of my cousins sent me a WhatsApp from India saying, do we need, the latest policy from Modi on COVID-19? And the WhatsApp was can't we have Jacinda instead? Meaning, can't we have the Prime Minister of New Zealand? She seems to be doing such a better job. So politics matters, and what type of leaders, not just whether they're women and men, but also the social policies they're able to bring into view. And I'm so glad the last speaker talked about data. It's one of the key points in my presentation is what we need to do much better in getting access to data. But I also have to say, if you look at who is producing evidence, where does evidence come from, women researchers across the board have fallen behind because we're looking after a lot of the household responsibilities have fallen on our shoulder. So that was just a kickoff of sharing reflections, listening to my fellow co-panelists. I have a few things I'd like to share with you based on what can we learn from the pandemic to inform the future of health systems based on research. Pulling a few things from a process I've co-convened. I'm based at the University of the Western Cape in South Africa at the School of Public Health. And over the last year, I've been co-convening a public process for setting a research agenda on gender and COVID. So why does this matter? We must do better. So although gender is recognized, it's striking, talking about research capacity, only 4% of over 4,000 clinical studies have actually, when we track this, reported a plan to include sex and gender analysis. It's been phenomenal, the scientific response, but we actually don't know what are the differentiated effects for women and men, and that's come up as a priority to rectify. Global 50-50 or Gender 50-50 has reported this. They've looked at what do we know in terms of data from health management information systems across countries, and it really varies. Yes, we know out of 205 countries that 180 have sex disaggregated data on cases, but look at the information of how many are reporting on testing, hospitalization, ICU admissions. It's very varied and we should be doing much better. Emerging study from Brazil looked at who got access to PPE. And although the health workforce is very delivered by women, but led by men, if you look at who got the protective equipment, 63 of physicians who are largely male and white did receive protective equipment, but community health workers who in Brazil are largely Black and female, they didn't get as much access to PPE. And they're the ones on the front lines doing all the community engagement. So I think these are things we have to do better on. And UNDP tracked when it comes to decision-making, where are we? Are women a part of the decision-making? And on average, only 24% of the membership of the task forces around the world had women included in them. So looking back at the pandemic, there's lots to improve on. And what could we do better moving forward? So it's not just me alone that's saying this. I just wanted to say that's been a process over the last year of holding webinars. We had a public discussion board. We had surveys. A lot of it was done in English, but many different key points of engagement were translated into other languages. And here are some of the priorities that colleagues have flagged in terms of gender. First, I wanted to flag, and our last speaker spoke about, in a sense, who has access to technology. And Marlies Richter from South Africa really said, we need to look at intellectual property protections, what's happening with patents, who has access to technology, and if not, what are the disproportionate effects on those most marginalized in the global South? This is a very live issue given that the WTO recently has not taken up the TRIPS issue. In terms of health services, we had 5 different themes. I'm just going to share some of the highlight issues. We looked at multiple things around health services, from access and quality of care, service delivery models, human resources for health, medical supplies, health information, and health financing. A lot of the questions were that we felt we needed to get better evidence on, and there have been studies showing the effect of the pandemic on maternal mortality, neonatal mortality, what's happened to sexual and reproductive health services because women couldn't get access to services, what's happened to chronic conditions, non-COVID-19 conditions by gender and other social categories. So a lot of questions around access, but also a lot of questions on how did governments respond, knowing those inequalities? How did they respond? How did they change how services were organized to improve the response? One quick slide on the theme on governance. The first question, as our last speaker emphasized, was getting better data. We need to support our national statistics systems to produce and use sex and gender data during COVID-19 and for future health systems. We just cannot continue to operate in such a blind manner. In the health sector, that data is there. It's not that we don't collect it, but it just isn't passed up through the system or retained. There were broad questions that were prioritized on what would our health system look like if we actually eliminated gender bias, and some future scenario building in that sense, and really looking at decision making, who's at the table and how do we change who's at the table and how we learn around these things. One participant mentioned that, in a way, I like this quote because it was, research is important, but we also need research or action that responds to, at the grassroots level, looking at community engagement and support, very much reinforcing Sushil Baral's point earlier. So this is my last slide, a takeaway of the core messages coming from this initiative. There's a lot we can do if we think of health systems, despite the scientific innovations that have happened. We really need to get back to the basics in terms of sex and gender, in vaccine and therapeutics R&D. We need to get access to the data, and people need, scientists need to be encouraged to be having sufficient sample size to be able to do that disaggregated analysis. We simply don't know enough when it comes to pregnant women, issues of menstruation. There's a lot in terms of how our hormones respond. Our biology is different, and we can't use men as the norm any longer. Once we get past the patents, we really need to look at how do we improve vaccine hesitancy and uptake. And this has huge implications for men as well, understanding what holds people back if vaccines are available and how do we improve that. Looking more broadly at health and well-being, particularly given the implications for gender-based violence, which have been massive because of the pandemic, and mental health issues as well are really important to pay attention to. And a lot of implementation research to look at how do we change our health systems? How do we create more gender responsive policies that address the inequalities that we see? This includes multi-sectoral action because a lot of the determinants of health are outside health. And the last point is to really look at a hard look at the power dynamics in health systems decision-making, and how do we make sure that the right people are at the table using the right type of evidence to improve our response to COVID-19. Thanks very much.
Thank you, Asha, for bringing that critical perspective, and it flows on very nicely from Dr. Chatterjee's focus on inequality, and you're drilling down on one of the primary stratifiers of inequality, gender, and illuminating how long-standing gender inequalities have manifested themselves and perhaps been accentuated in the context of this crisis across a number of the areas that are so critical related to knowledge, to delivery of services, and even politics. And then you've given us a pretty comprehensive prescription on how research can be perhaps more gender sensitive and equitable, spanning vaccine through to not only the political power processes, but the political power dynamics, but also the equitable processes for inclusion. So a great way to conclude the initial remarks from the panel. And we're doing very, very well on time. So I thank everybody for being so conscientious with respect to their allotments. We do have some questions in the chat, but while I prepare those, I thought I would just throw 5 questions out to our panelists and have one quick round of response. And Dr. Kwok, you have the privilege of being in the academic ivory tower, and you made some comments about it being too slow to perhaps react in the current setting. It'd be great to hear a little bit more on how you think academia should reform to perhaps be more relevant and value added. So that would be your question. Dr. Baral, on PHC, you mentioned workforce, community, and sustainable financing as critical resources. How would you integrate the techno innovation into that? How does that sort of interface with those 3 critical resources? Rob Yates, you mentioned heads of state as being absolutely critical and taking advantage of the crisis. We didn't hear much from you on their leadership importance in the multilateral frameworks. And we've been aware that big commitments have been made, but there's been precious little follow through on those commitments. What are your heads of states and their roles with respect to the global preparedness that we need to commit to moving forward? Dr. Chatterjee, on your inequality and knowledge systems, you identified a whole set of issues in the data environment that we find ourselves in. It'd be great if you could give us a sense with respect to the critical issues that you identified. How should we be addressing something like misinformation moving forward? And finally, you gave us that strong gendered lens, which shows that we have so much more to do with respect to the inclusion of women much more centrally to move things forward. What are your thoughts on making up for the decades of progress lost? What is the agenda for really making up that ground as quickly as possible? So those are just things, a few questions. I'm going to begin with Dr. Kwok and we'll move. No need to spend too long on these. A minute or two is fine. And then what we'll do is we'll move to our questions that have come in from the audience. So why don't we begin with Dr. Kwok?
Thank you, Dr. Evans. Just very quickly, I think there are different phases in which academia works within. Of course, there is pre-crisis, which could be even now when we are looking forward in preparation for the next crisis. This pre-crisis phase, you can tell that there were books out there and articles about preparation for pandemics, which never really got people's attention, especially the policymakers. So zoonotic transmission, for example, was well known, but when it was not, when it actually did happen again, it was not responded to very quickly. And then moving on to the real-time evolution of a pandemic, the immediate and the short term, I think academia sometimes is not well poised for this because of the way that research is being propelled by grants and the need to apply for grants and so on. Of course, many governments and grant agencies did respond very quickly to this and rolling out grants for very immediate research topics and so on. But the publication system, which involves a lot of justifiably peer review and so on, for an article to be published, it takes time, and this lag time is where the pandemic is unrolling in very dramatic ways. So there has to be also a kind of timely responses in which it's true we may not have all the known knowns and the known unknowns, but there's a lot of intensive questioning in which interdisciplinary teams are pulling together to think through and to support the frontline workers and state actors and civil society actors. Last but not least, I would say that academia has a role to play in public education, especially now with all this talk that we are discussing about lessons. It's remarkable how lessons can be so easily forgotten, even the lessons of SARS, for example. So this should not be repeated. The lessons of COVID-19 must somehow be worked through and packaged and be able to be recalled in accessible ways for the next crisis. Thank you.
Great. Thank you very much for that concise and really illuminating answer. Dr. Baral, the role of technology and innovation in PhD.
Thank you, Chair. It's a very good question. I mean, we live in a digital world. We cannot survive without technology here. So the primary healthcare, there are ample opportunity to integrate, relink primary healthcare services with the technologies front. For example, in order to empower our healthcare provider, frontline healthcare provider, who are often multitasking, Taking the example of Nepal, we have the hill and mountains where the access to various technologies are limited. However, for example, one of the examples that we have been doing is the telemedicine, reaching out to our primary healthcare providers who are on the rural area, bringing the technologies closer to them through the telemedicine. And also we have been trying the drone technology in terms of delivering the drugs, essential drugs, for example, tuberculosis drugs up in the mountain and hills, that can be incorporated within the primary healthcare system in order to advance the care delivery mechanism, which is much more prompt. Also, we have this data digitization. We often talk about reaching to the community, empowering community through a data digitization, having a personal family follower, personalized support in terms of like changing their behavior, using through mHealth processes. Also, we have this in a opportunity to have real-time data to be collected out on the periphery level. So the dashboard, the well-displayed real-time dashboard can help the policymaker in terms of making their decision choices, which are linked to the people's health need, population health need. So there are ample opportunities to advance, to relink and integrate technological advancement towards accelerating the primary health care, which is very important. I just want to link with Asha's saying what he said in her presentation, that data matters. The data, disaggregated data, making available to the policymakers and with the community in order to understand who is out of the scene or who is taking the advantage of the primary health care. So there are ample opportunities to really integrate and get the reap of benefit from the technological advancement towards changing the primary health care towards more quality, more patient-centered, more integrated, and more comprehensive and continuity. Over to you, Chair.
Great. Thanks so much, Dr. Baral, for that really interesting example of how digital innovation is so central, and linking it with Dr. George's presentation. Rob, over to you. What are the heads of state doing above and beyond their own countries?
Well, precious little, unfortunately, and this has been one of the great tragedies of the whole COVID response. That this was a global threat that required a global action, and clearly required collaboration and really solidarity. That is all helping each other out, and this mantra of no one's safe until everyone's safe just cried out for our countries, particularly rich countries, to support obvious things like sort of universal vaccine coverage. And I think that the vaccine nationalism that's been just so apparent through this crisis has been an absolute disgrace, to be honest. And that the G7 and the G20 have failed repeatedly through the crisis to do anything about it. I think it's just very unfortunate that this crisis hit when we did have a particularly bad generation of right-wing nationalist leaders, and that when you've got the president of the world's richest country undermining the World Health Organization and threatening to cut its funding, it just sort of beggars belief. And so different, I think, to about 12 years ago when we had the financial crisis, and there was a lot of cooperation through the likes of the IMF, with as sort of sorting out the banking system. So I think it's beholden on all of us to get involved in the politics of this, and to be perfectly frank, to try and ensure that these nationalistic sort of right-wing leaders are replaced with leaders who are smarter and recognize that we do have to collaborate across the world. And there are signs of this happening. I think in Latin America, you're seeing these leaders being replaced. And it's beholden on all of us, I think, in public health to get political. We just can't, ignore the fact that our leaders are letting us down, and that it might feel a bit uncomfortable sometimes, but we just have to do it.
Thanks, Rob. Move now to Dr. Chatterjee and your thoughts on the simple issue of misinformation.
Yes, but before I come to that, Tim,
Yes.
let me make a point about the need for collaborating with decision makers on evidence that are produced, particularly in LMICs, and early engagement ensures local relevance, ownership over the process, policy buy-in, and continued engagement. So we have to look at the issue of use of evidence with a new lens, and look at whether evidence production should be embedded in national priorities. Sometimes independence of research is necessary, or the mix of the two or other approaches maybe considered for different approaches, for different contexts. Because simple production of evidence or data or knowledge it does not necessarily lead to its automatic use. We have seen that over and over again. So that point I wanted to make. Secondly, on misinformation, we are only beginning to understand this phenomenon of misinformation, and the first sort of crop of research has started to become published, looking at network and looking at some experimental studies. But the key problem in this area is that social media platforms rarely provide data to misinformation researchers. This is problematic as platforms play a major role in diffusion and amplification of misinformation narratives. And scientists who are working with this, researchers who are working with this issue, are left with incomplete data sets, sometimes using experimental models which have experimental designs, which has external validity problems. So it has not been easy, or I've followed this area for some time, and I think the solution to this is investing much more in understanding and researching this global phenomena. We frankly speaking, we do not understand misinformation very well. We describe it in different terms, but the motivations, the typologies, and what other and different other aspects of it are still quite poorly understood, and therefore I think this is an area of investment in research, is what I will say. Over to you.
Great. Thanks so much, Dr. Chatterjee. And with that, let's go to Dr. George and your thoughts on how we can catch up for all the ground that's been that we've been lost.
Sure, certainly. And I just want to reflect on the last speaker. I think a huge part of misinformation or the infodemias that have been happening have to do with issues of trust also. And when you're working with marginalized populations that have always been at the either neglected or criminalized by public policy, it makes it even harder to reach out to those populations until we understand that their historical relationship with state authority. And that certainly has been amplified by social media. How do we catch up in terms of gender inequality? I want to focus on one issue, which is gender-based violence. In Nigeria, in the first 2 weeks of the pandemic alone, first 2 weeks of the lockdown, domestic gender-based violence increased by 56%. It's just been a highly, it's just ripped the Band-Aid of something that over time, we've had better data on what is the extent of gender-based violence, but the pandemic and the lockdown, the lack of jobs, but also the restriction of women in households with their abusers just increased the level of gender-based violence. So what can we do about that? What was striking is if you look across Africa, there were a number of initiatives that governments did step up. For instance, I think it was in Mozambique, there were particular media awareness campaigns that were done in terms of raising awareness of gender-based violence. In Cameroon, there were also a hotline was set up to help women access services. So a lot of effort recognizing, and there were other places where you had special surveys set up to find out the extent of the problem. At the same time, we know that women, one of the problems with gender-based violence is that women don't feel it's safe enough to get help. So in a sense, a lot of the responses were not evidence-based based on what we know on gender-based violence. They were well-intended, but they missed the mark. At the same time, we had across the continent a lot of initiatives working with social policy on cash transfers. And cash transfers are an evidence-based way that have been proven to have an impact to reduce the vulnerability of women to gender-based violence. So I think we need to do more to join up. One, actually have policies that are based on evidence, but also join up across sectors. And what we could have done, and I think there's still room to do that, is looking at social policy responses like cash transfers, which were done across the board in several countries, and to look at how can that be not just to reach the most marginalized communities and families, but really you could have had a double win in terms of making those women who were very vulnerable to gender-based violence, helping their vulnerability and addressing that vulnerability. So doing more in terms of joining up policies that really look at the structural drivers of vulnerability is absolutely key, in addition to improving awareness and things like that, but really addressing the structural elements of inequality is key. Thanks.
Great. Thanks so much, Dr. George, for that. We have 8 minutes remaining, and I just want to acknowledge that we have 10 questions in the chat. We've reached double digits. We have a couple from Mohammed that asks about lessons learned with respect to data collection, management, analysis, and dissemination, and how you can maximize benefits at minimum cost in communicating and integrating preventive and clinical care. We have a question from Azia on representativeness in leadership and governance, and how by including the affected and marginalized, that might lead to more effective communication, community engagement, and mobilization, or does it? Nur Zaman is asking us whether equity is a myth, given the behaviors we've seen around vaccine production, distribution, performance of governments, loss of jobs, and the new crop of billionaires that have appeared. We have an anonymous attendee who's said the US has the highest infections and mortality. How do you explain that in the world's richest country in terms of public health systems and primary health care? We have Saiful, who has asked a question about what's the future for cost-effective healthcare systems in the developing world in the near future. We have Zeal, who has asked what is the importance of electronic health records in low and middle income countries. And Jafar, who also notes Europe is very high infections and mortality in the midst of plenty of vaccines. Thoughts on that? We have Anna, who asks questions about how a researcher can manage the flood of information, especially if your first language is not English. So is there a way in which you can triage and filter so that researchers can have a better understanding of what's going on? So I will give each of our commentators 30 seconds to make a quick comment on any one of those questions. And I'm going to do it, reverse the order. Dr. George, you have 30 seconds.
I think the issue of getting, there's been a huge opportunity in this crisis. It's brought together many more people to be concerned about gender and COVID-19. There's a gender and COVID-19 working group that has so many more people have signed up who are outraged about what has happened. So I think that mobilization now needs to translate into evidence, but also engaging with politicians and asking questions as basic as the data. The fact that I think at the beginning of the pandemic, we've often jumped to conclusions in terms of who is most affected. And then we look at what's the basis of those conclusions, and we see how little consistent information there is about sex disaggregated data. And the pandemic keeps evolving. We then have long COVID. Now we move to vaccines. Now we're moving to boosters. The evidence needs are changing constantly with this pandemic, and we need to be able to keep up with that and have real-time information that's sex disaggregated. Thank you.
Thank you, Dr. George. 29.7 seconds. You set the bar high. I will go to Dr. Chatterjee.
In terms of managing, I'm taking that question on what to do when flood of information coming. One way to deal with it is to be part of research networks, and a lot of different types of information also coming. And being in a network helps us to digest that information and use it in ways that are useful to us rather than being overwhelmed by it. So that would be my response. Over to you. Thanks, Tim.
Great, thanks so much. And you've set a new bar. That was 19.6 seconds, Dr. Chatterjee. Rob, what are your thoughts?
I'll take the equity one, I think, Nurazaman's question. And I don't think it's a myth, equity. And I think we've seen very good examples, within countries often say vaccines being allocated equitably, so the most needy getting them first. The problem has been, across countries and the multilateral attempts to improve equity haven't succeeded as well as we'd like. Perhaps we were a bit naive. But then I think there are attempts to tackle that. I think you are seeing some governments stepping up now, and Costa Rica and Cuba and other governments who see this differently. And so it's going to be a political battle to make sure that we are more equitable next time round. And I think there are players who are taking this very seriously. So I'd like to think next time round we're going to do better.
Thanks so much, Rob. Dr. Baral, over to you.
Yeah, I'll focus on the EHR and the importance of EHR. I think one word is during this pandemic, the whole world massively suffered about the care coordination mechanism. When there was a high peak of COVID in each country, and we massively suffered in terms of placing our patient in appropriate facilities from the higher facilities to the lower primary health care. I think having electronic health record that basically focuses on individualized data and supports the referral mechanism, the care coordination processes across the mechanism. That is an investment for high return in the future. Although initial startup costs would be high, there are technological advancement which we should be aiming at EHR in primary healthcare as one of the pillars to strengthen. Over to you.
Great. Thanks so much. And finally, Dr. Kwok.
Well, I see that everybody's avoiding the question of the great USA. Now, I think we won't have time to go into it, but there was a magazine cover provided by Mr. Yates earlier on, which may explain a lot. But I think also that Dr. Baral mentioned leadership being crucial. And I would like to say leadership at every level, and not just at the head of state or at state level. There's a great need when leadership fails at the highest levels for other people to step in and find ways to compensate and to even resist some of the very, very wrong and misguided things that have been said or done. The fact of the matter is that COVID makes all of us humble from any country, any part of the world, including the USA or even Singapore. It's been such a challenge, and it's been endless. So we do need to have a great deal of humility about going forward. And really, when I mention desperation and devastation and despair, you just think of those times when doctors and frontline workers had to decide who were to be treated, who were to be put on ventilators and so on. If we can just remember that image, you would never ever want anybody to go through that experience, or the way that Delta surged in certain countries to the extent where you don't even have enough facilities for cremation, for example. Those very, very painful moments, I think many people will think that they are better forgotten so that we can get back to the so-called new normal. There is not going to be a normal anymore. And whatever is new has to be created out of this very, very challenging time that we are living in. I'm sorry to sound so philosophical and feel perhaps a bit helpless, but I think this conference has showed that if we pull together and if we do things together, also with the use of technology, we can in fact be better prepared. Thank you.
Great, Dr. Kwok, and I think you've really brought things together in a very nice way. And so you've made my job much easier in terms of synthesis. I'd just like to thank, first of all the participants, those who provided those stimulating questions. To our panelists, you've been absolutely brilliant. A fantastic range of perspectives that's been shown here. And I can't imagine a more enriching 80 minutes for anybody who's had the opportunity to listen to this. And then finally, to our presiders who organized this and to Bangladesh Health Watch, it has an esteemed tradition of focusing on critical issues that are not only important in Bangladesh, but in the world. And I'm grateful that they continue to provide opportunities for all of us to learn. My own reflections very, very quickly is that a little bit like Richard Horton's syndemic there, and Dr. Kwok said that there is a new world, new brave world that we've launched ourselves into with this pandemic. And it's not one, but it's multiple crises concomitantly. And we will be facing those not in 100 years, but every year. And so we have to adjust our systems very fundamentally. I think we have to be humble in that our learning has to extend well beyond our traditional norms, and that it needs to think about contextual specificity, national systems, and very importantly, transnational systems. And I think on all those fronts, the learning agenda is incredibly rich. Some of the dimensions that I think we have to really bring into focus is the imperative for speed, because it matters when you have a crisis, and our systems are often built for peacetime. We have to understand how we can continue to learn as we run, and that includes us being nimble, smart, and savvy. And I think that is, again, has multiple levels where that importance of learning on the run has to manifest itself. And then finally, I would say we have to make sure permeating everything we're moving forward with is that we sustain a strong sense and renew our commitment to solidarity. I think without that, we risk some of the massive fragmentation and intolerable inequities that we see. Above all, I think it's important to be very suspicious of single fix-all solutions. Those are just a few thoughts from the cheap seat, but I really stimulated by a fantastic panel, and I would like to finish and hand back over to Dr. Chowdhury at this time.
Thank you. It was indeed a fantastic final session, and fully lively, informative, and so engaging. So thanks all the panelists for your time and for your commitment to see the next health system, which will be more equitable and available to everybody and accessible. So with this, we conclude this final session. And thank you again, all the panelists, Aninda, Rob, Asha, Kwok, Sushil, and of course Tim Evans, who is my friend. Tim Evans for chairing this session. So this comes to the end of this session. Thank you very much. Thanks everybody.
We have about 20 minutes of just wrapping up and thanking everyone. So bear with us. I just wanted to, first of all, because I want to take this opportunity because Richard Cash has joined us. He's incredible experience around a lot of these issues. If he could just say something for a couple of minutes, given he's taken the time to join us, Richard, and then we'll just conclude with a few key statements and thank everybody. Is that all right? Given we're already up and around, thank you so much, audience as well. Hi, Richard.
Well, hello, and hello to everyone who I think I know almost everybody there. And I'd like to thank the panel for a really fine discussion. I do have one quick question, which is probably an uncomfortable one. There's been a lot of talk of equity and a lot of talk of making sure that everyone is treated equally. And yet we've tended to ignore, and we've defined equity almost as what the wealthiest countries have. But is that really what we're looking for? Why haven't we spent more time in thinking about individual situations? For example, in sub-Saharan Africa, lockdowns were probably a very inappropriate thing to do. Asha reminded us of all of the domestic violence that occurred. Why was this done? Why in an area where there is a much, much, much lower mortality per million, are we striving to try to immunize everyone? Does that really make sense? In other words, should we not be spending far more time in developing interventions that are really appropriate for the countries and their own situations? This disease is not one that affects all countries the same. If you have a young population, less obesity, elderly are not warehoused as we do in the West, mortality has tended to be much, much lower. Even the best health system, or that's not the word I'm looking for, the most technologically advanced system hasn't really done much good. The United States has one of the highest mortalities per million people. Compare that with the mortality in Ghana or many of the other countries, which supposedly have far fewer resources. So I would put in a plea and ask that countries develop strategies, though we are all in this together, as someone said, that are appropriate for their culture. Bangladesh has a much lower mortality than does the United States, for example, despite having a population density that is the highest in the world outside of certain city-states. They've done much better than India, as has Pakistan. We need to look at this data and decide who and what each country should undertake. I don't agree with this notion that no one is safe until everyone is safe. I think that's a good bumper sticker, but I don't think it reflects reality. And it certainly doesn't it certainly doesn't address the tremendous differences that we have seen between one country and another. Sorry to throw that in at this late stage, but I think it's for the next panel, for the next.
I think it's
conference, you
important.
can take that
Thank you,
issue.
Richard. The whole idea of the 3 days has raised lots of thought-provoking discussions, debates, very, very rich presentations. I'm not going to summarize. The plan was for me to review all those sessions, but we are coming out with conference proceedings. But what reminds me is the power, politics, and evidence that informs or misinforms the way COVID responses have happened on the ground. And I think it's extremely important to look back at some of these sessions and how it sheds light on lack of trust or predominance of certain methodologies, how the power of social sciences can impact and transform, how certain groups are invisible, the fact that we don't have gender sensitive research, it's critical for that. Intersectional factors are important. But just to wrap up with, we do need a broader view of health sciences systems. Women leaderships are missing, but many groups are missing. Class inequalities are increasing. Gender inequalities are missing. Lots of disparities within countries, across countries, and there isn't a socially just model. We need universal solidarity and accountability with the whole vaccine equity. And just to finalize, before I ask Masood Bhai, who's one of the organizers with us, James P. Grant School of Public Health organized this with Bangladesh Health Watch. So I'm very proud that all of us came together to do this today. I'd like to thank all our rapporteurs, Wafa, Frida, Tamid, Imtiaz, Momita, Bushra, Naitun. I want to thank the Bangladesh Health Watch team, Mashudul, Bushra, Najmul, Noshin, Moli, the BRAC James P. Grant IT team, Kabir, Habibur Rahman, Mahmood, Rauf, and Mizanur from BITS. Finally, under the leadership of Onubab, across the entire team is Onubab from the communications JPG team, Muqbul, Asif, Nurzaman, Supriti, and Shariar. So thank you very much. And thank you to all the panelists over the 3 days, the audience that have listened, engaged, asked questions. We couldn't have done it without you. We really, really appreciate your intellectual contributions and insights. Over to Professor Masood to wrap up. Thank you very much. Stay safe, stay well. And we'll be together again online or in person, who knows? May our paths cross. Thank you. Masood Bhai, you're on mute. We'd love to hear you, but you're on mute. Thank you.
I was telling that there's not much to add from my side. First of all, thanks to all the participants, panelists, especially the chairs, and our those people who were behind your computer screen, who worked a lot this last 1 month or more. So thanks to them and for their tireless effort, this thing came to a success. It came out smoothly. So with these few words, I will thank you again and have a good time, good day. See you in future, sometimes in a different conference. Bye.
Bye-bye. Thank you.
Thank you, everybody.
Thanks, Mushtaq Bhai. Thanks, everyone. Thanks, Richard.
Thanks, Richard. Thanks, Asha.